So the patient we have is a 4-year-old with a 6-month history of facial swelling, initially noted in the morning, subsiding during the day, now present every time that he is supine, subsiding when upright. We first saw him in 2016 at the age of 9 months with poor feeding, persistent dyspnea, excessive sweating, and failure to thrive. He was 4.6 kgs at the time. On evaluation, he had a 10 millimeter perimembranous VSD, 7 millimeter inlet VSD, additional anterior muscular VSD, severe hyperkinetic PAH, PAPVC of right upper pulmonary vein to the SVC above the SVC array junction. Surgery, he underwent surgery with closure of the VSDs and had a Warden's procedure. Of note is the azygos was divided at the time. He's been on follow-up with increasing turbulence noted at the SVC array, right atrial appendage anastomosis. Initially asymptomatic, presently symptomatic as stated before. He is 12 kgs against an expected of 16 kilos, saturating at 98% on room air. Normal blood pressure, mild facial puffiness with no obvious neck vein engorgement, no cardiomegaly, pulse is irregular, normal heart sounds, chest x-ray, cardiothoracic ratio of 55% with the left touch. With ECG findings, sinus rhythm 82 per minute, QRS axis of 60, there is an RSR pattern at V1. Of note on echo is that turbulence SVC 2 array with a peak gradient of 22 millimeters of mercury, mean gradient of 14. He then had a CT scan done that showed SVC narrowing, compressed side-by-side compression, narrowest portion 3.5 by 7 millimeter. The stenosis was about 20 millimeters long on the CT angio. So in summary, status post VSD surgical closure and Warden's procedure, now presenting with SVC right atrial appendage narrowing for SVC stenting. Thank you.
Hello, good evening everyone.
Yeah.
Dr. Tin is in charge of the team, and I am Dr. Umamaheshwar, and she is Dr. Ansu, and Mohammed is a technician in charge who is doing all take care. Dr. Tin, please.
Now let me start with the angiography. You see, we cross the guide wire and put the detail in the SVC. The pressure in the SVC is very high.
You are holding here.
The mean pressure about 30.
Sister, you are holding
And
one,
we
and
did
I am holding
angio.
one.
You can see the angio is very severe stenosis of SVC under the vertical vein to the right atrium. And you see some collaterals from the neck to the azygos vein. And we measured the length of the stenosis about 30 or 33, and the normal size of the vein above about 10, and a little bit oversized, but I think about 8 to 10 mm. And our question is, should we use stent or just balloon? And if you use the stent, what kind of the stent? Cover stent or pigmental stent or open cell stent? Which one? I need some advice from the audience and panelists.
So what narrowest diameter you mentioned is 7.
Do you think a balloon is enough? Yeah, the normal size.
Tin, I've had the difficulty once or twice with these stenting. They're extremely fibrotic, so wouldn't open up with the balloon, even including near medium pressure balloon up to sort of 12. So we had to use a cutting balloon first, and then we opened up with the high pressure balloon, and then we put a stent. So that was one of the questions, whether you would do something like that, or
you test the compliance anyway?
Compliance, yeah, I would test the compliance.
Will you pre-dilate and find out the compliance, or what is your plan strategy? That's the question from a panelist.
What advantage with the balloon before the stent? What advantage? Or can we go with directly with the stent or something else?
No, that was our question. See, in this case, like Dr. Shreya was saying, it may not open, especially this post-surgical thing. So we would like to know how compliant this is before choosing a strategy. So some form of balloon dilatation is what the panelists feel may be appropriate to start with to test the compliance, not exactly balloon dilatation.
Yeah, I would probably definitely do that before taking the stent, because you can have slippage of the stent, or you might be in difficulty later on.
Very well.
Yeah.
Dr. Tin, you could hear
But
that?
you think you're worried about the thrombosis? Yeah, we can hear
No,
you. But
Tin,
you worried about the
what's
thrombosis
your
or
plan? What is your plan? You tell us what is your plan.
I intend to go directly with the stent, but because I think the HVCs, the compliance is not so limited. I think we can use the stent directly, but we can try with the balloon to see how about the compliance of the HVC.
Sure.
And okay, give me the
Yeah,
balloon.
Dr. Shreya's concern was if the stent
Then
doesn't
30.
open up when you
No, the
go
second thing
directly.
is sometimes it just opens up well with the balloon, and then you don't need a stent in a smaller
20.
child. Again.
20.
Longer.
Longer.
I do not know.
40.
Yeah, just tell you.
So, what are you going to do? Dilate with the balloon? Then in that case, what's the size of the balloon
Yeah,
you are going to
20
use?
ml syringe.
Yeah, and what the size of the
Diluted
balloon and
dye.
the
Diluted
length? What size of balloon you want to reach?
So you measured here narrowest point is 7.6 millimeter, I think.
Yeah.
The one is 10.
Can you show the video? Run the video. No.
Previous one.
Previous one.
Stop.
X4. X4 is length.
Open the.
Sister, that op.
Then have you chosen a
Open
balloon?
the silent.
Probably 8 or
Yeah.
10.
What is your choice?
And the maze.
Probably
Sorry, I cannot hear.
10. What is the size of the balloon you have chosen?
And which balloon?
We
12 into 40.
Did you
12
say
into
10?
40.
12 into 40
What
Mustang.
balloon?
yeah, 12 to 14.
What is the
Mustang
balloon?
balloon.
Mustang.
Mustang is that's an extremely high pressure balloon, isn't it? You can go up to 20 even. Mustang.
It's the balloon in middle.
We need to pull it back.
Yeah, that's. It will be deal with this.
Yeah.
Fine.
This is a good balloon, very tight.
Okay. And now we dilate the balloon fluoro. You should. Sorry. Again. Okay. Advance the balloon. Balloon is. Okay, a little bit higher.
It's pushing.
Yeah.
Can you tell us the pressure that you are using?
Yeah, you see the stop fluoro. Stop fluoro. Okay. Oh, and you see the balloon. The size of balloon is 12 and 14. 40. Sorry. And you see how compliance of the HVC.
Yeah.
So it is completely yielded at 14 atmospheres.
Yeah. Advance the switch off. Wait for me. And hit the bump. Okay, advance the switch. Advance the switch up to the. Okay, good. Can you back the previous?
You're doing an angiogram?
Previous. Yeah. Yeah, I did already. Now I do enjoy angiogram
balloon.
again.
Remove, sister.
You want? No. You hold the wire. Remove.
Because you had asked a question as
And
to
now
whether
after the balloon,
you had asked a question whether we should choose a bare metal stent or a covered stent. What happened to the vessel wall
Yeah.
after the balloon dilatation might give the clue.
Absolutely, I think. And also we will know whether
Wait,
it's
one minute.
required or not sometimes.
here she removed the. Okay. See now. Now what do you see? And
Yeah,
should we
inlet
use
partially,
the
yeah.
stent or just a balloon is enough?
It's yielded.
Can you measure again?
It is
Can
yielded
you measure
somewhat,
again?
no damage done. So obviously a bare metal stent will be
Can you measure again? I think now we after the balloon dilatation, I think the HVC become bigger, and we measure the size
I think you have
and
to
we decide
recheck,
the stand later.
recheck the diameters now.
No,
measurements,
the final one, not the last one.
I think one
The
of the
last
things
one.
is it should be discussed with the family as well. If it yields well with the balloon and they're okay for the second balloon or third sitting, I wouldn't go ahead with the stent in a smaller child. I would do another balloon telling them
Exactly,
for a closer
exactly.
follow-up, and then you can put the stent later. So I would always discuss this with the family beforehand, because sometimes like this is a good result for me.
Yeah.
recently. So,
But we can
You
use
can't
the open cell stand, and it means we can further dilatation later.
if it is
So, Dr. Tin here is one
Yeah.
discussion here. I think now it's a reasonably good result. Do you want still go ahead and do a stenting, or if if there any reason, probably you can go back and dilate later on.
We'll connect the pressure and tell them.
What's your thinking here?
Mm. Yeah. I'm thinking. I don't think when I put the balloon, dilate the balloon, the HVC looks better like this. And maybe I change my mind. Just balloon only is enough. No need to stand too early for the spawn baby.
Would you check the pressures as well?
I think
How the gradient is
Pressures are
behaving
still
now?
there.
this is happening slowly after 3 years after surgery.
Yeah.
Put in
But if the pressures are
this is
also
what French?
This is
6,
8
8
French.
If you take a 12 millimeter Admiral X-ray balloon,
stenting in a
take the
smaller
formula
child
stent
for a
out and
venous
mount it
system,
on
I
the
think
base.
I would be very
Or I
careful.
can give you another 18.
And I think that's
What
the
is the
reason I
length?
tell that it's
Length
very
is
important.
30.
We shouldn't not be
We are
making
taking
policy
40.
decisions. Part
Length
of
is
the decision
30,
should be
coming
made by
30.
the family as well.
We are taking
And
40.
they should be involved closely.
So
Ten
that
and 40?
All the planning
So
before
already
you
taken
get
out?
into the
Cook formula.
I think you
cath
can
lab.
use
So
and
that
use
you know exactly where you're going to get out.
not yet.
You
Not yet.
deploy it, and then you post dilate with 12.
Yeah, 12. Yeah. And I discussed with Siva.
Yeah.
Now you see the pressure,
Pressure is still-
of the HVC trough very not traumatic, but I think it's good now. But the risk of the restenosis of the HVC is very high. And so if we just balloon, we may balloon many times.
So you would go ahead and stent it now.
Yeah, and we think the small baby, small child, and we prefer to
Admiral
use
X-ray.
the open cell stent, and this is a formula Cook stent. I prefer to use the length of the stent about 40. I want to cover a little bit longer, and the size of the stent about 10. It means we can first dilatation at 12 or 14 later. But 10 now is okay, not too much. Oh.
Can you explain the choice of your size of the stent, the diameter? How did you choose it in this case?
No, wait.
Student.
Dr. Tin,
Sorry, I cannot hear.
why
I
did you
guess-
choose a
yeah.
10 into 40 here? What is the
The 10, how did you
Your-
choose?
What size you want?
What was the
I think the normal size of the normal size of the HVC about
Okay.
10, and I think it's we don't need to to oversize. The stent can be dilated further, and no need to put very big at first.
What is the narrowest diameter now after balloon dilatation?
Can you measure the narrow one after balloon? This one, the narrow one. The last one. Yeah. The sheath is the 8 French sheath, and the smallest one. I think about 2 or 3.
3 almost.
About 3 or 3.5.
Okay. So we are effectively
I think 10 is
3
enough.
times.
Yeah. 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 Maybe.
Contrast.
And now I check the position of the stent. The formula stent 10 mm. We can go with 7 French, but I prefer to use the 8 French sheath, and I can do angio easier.
Okay.
And what do you think? I think just a little bit below and it's okay, or just here it's also okay.
You're going to deploy
And
this
now I
at the
uncover
nominal
the-
pressure, no? You're not anticipating
Yeah.
any foreshortening because your deployment
It
is going to
doesn't.
be at the nominal pressure.
This will not. This has got
Yeah,
less
yeah,
foreshortening.
yeah.
Good formula, no?
Yeah.
Yeah.
Performance is less foreshortening.
Yeah.
Okay.
Doesn't have less.
About 10 or 15%.
Yeah.
It's okay. A little bit lower. It's okay. Okay. Can you hold this? Can you inflate or? Do you think is the position of the stand is okay?
RBB.
It looks very good.
I'll start
Okay.
different.
It's
Okay, go.
near
go.
denominate.
Slowly.
I think that's if it doesn't foreshorten much, then
Yeah.
that might be a problem over time.
Oh, you should. Okay, go. 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 How much?
4, 3. Nominal is
Nominal how much?
8.
Huh?
8.
8. Go to 8. Okay.
8.
Okay. Deflate.
Deflate.
Can you store? It? Yeah. Okay. And can you run again? Play again. Yeah. What do you think now? I advance the sheath to
I think all of us will do it slightly differently. I would
Okay.
usually do a veno-venous loop from the RIJV whenever
Can
I have
you
done it, so
advise?
that for injection and for stability, and I use the same Terumo wire and
Can
then
you
deploy
put
the
back
stent
the-
and then do the injection from the top just to see a stent position. But this is also
Should I
actually-
pull?
Yeah. We intend to do this. Yeah.
Should I partially inflate
Yeah.
it?
Remove the balloon. Okay. Remove the balloon. Okay. Prepare the pigtail for me. Remove the balloon. Yeah.
You are posteriorly or
Yeah. We do enjoy and check again.
do angio,
Yeah.
okay. transiently can you give them to us, our lab, so that we can show some pictures? You can just tell them,
Yeah. Okay.
you tell them that we are.
Yeah. And then now we will do angel, and we back to you very soon. Siva, can you go to Siva? She want to show you some. Can you see the final angel? Yeah. What do you think?
Yes.
Oh, very good.
The pressure in HVC now becomes the normal 13 to 14 HVC, and you see no collateral, no
Yeah.
azigot again. And what do you think we
is
should
jail,
do
no?
further dilatation with a bigger balloon, or is enough?
But out till left denominate
In,
vein.
where is the left innominate? Can you see the left innominate? It is not filling by reflex.
Yeah,
You can see a
we
stump of
open-
left innominate. I think your stent is across the left innominate, is it?
Yeah.
When you open the stenosis, we normally we don't see the left innominate vein.
Concentrated yes.
Yeah.
Give an injection from
Would you be concerned about that?
Yeah. Oh. About what?
Put a balloon and dilate.
You need the further dilatation or not? And Siva will do the contrast from the left side.
The size of the stent wise, that looks okay. But would you delineate that innominate?
disconnect.
I think it's normally it's normal because when we open the stenosis, we normally we cannot see the innominate
This
vein.
plaster. Remove this plaster.
Siva, we do inject from the left hand.
Yeah.
And we
Show
can
me the
see.
scenic.
Uh,
Now get the left denominate. Good.
yeah.
Okay. I'm injecting.
Okay, inject.
It's moving. Inject.
Okay, ready. Okay, go.
Lift the hand.
Yeah, it's look normal.
then-
You see. Yeah.
Oh,
Okay,
no.
look, Siva.
Yeah.
I can put the Chaya.
Yeah,
And
see
some
now?
drops
See
okay.
now?
And want to make it sure that it's
Yeah, I think
Not-
no obstruction.
flow is not there. Flow is not.
This is a very tiny cannula.
But
And,
lift it once.
What do you think? You happy with that, or if you want, I can put the Chaya catheter to the innominate vein, and you can do angio and measure pressure. But I think it's okay.
Yeah,
It's
we'll
normal.
I think doctor
That's
can,
fine.
Get a RCA into the innominate.
Okay.
Yeah.
Put a wire across.
That will make it complete.
J
J-tip.
Judkins right.
Yeah.
You want J-tip catheter?
Yeah.
Cross.
No. The Can you remove
The
it?
problem's okay. Now we are doing.
And I will put the
Show me the
Chaya
lens.
catheter to the innominate vein to show about the pressure and the can push it. Just give me 1 minute. We will finish very soon. Hold on.
Dr. Anil? Next speaker is ready to. Yeah, I think we can have him on the stage because we are only demonstrating a small thing, no?
Yes. Dr. Shad.
Yeah. Please be ready as soon as this is demonstrated. Yeah.
Get a 6 Mustang balloon.
Yeah.
Advance it as deep as possible.
Yeah, that's okay. Training, all right.
It was going up like that. Yeah, that sounds fine. Advance the catheter.
There are some resistance. Okay.
Little bit if you advance and then put in the stiff wire, then it will be fine.
Yeah, maybe the stiff one.
No, we enter.
Maybe I go to
What French catheter is it? A 5 French or 4 French?
It's 5 French.
5 French. Get a 4 French. Get a 4 French. 4 French Judkins right. Quickly get it. Hey, Nadatike, there are 4 cases, right? Sanjay is what?
4 French.
PDA. No, no, big one. Ah. This is an open cell design. Huh? This is an open cell design.
Open one.
For French
This
jet
tent
kits.
is an open cell design.
For French, yes.
Get a slip cat, black color slip cat. Vertebra.
Siva, shall we do another talk?
Yeah, please go ahead.
Yeah.
Please go ahead, Dr. Suresh.
Yeah, thank you.
Well, I try to advance the catheter across the throat to the innominate vein, but it seemed difficult, and so I used the balloon. The balloon is about 840 mm, and you can see I cross the balloon. When I cross the balloon, I try to open the throat, and you see the balloon looks now the balloon a little bit resistant, but it's overcome the truth very easily. And you see when we deflate the balloon, we open the throat. Really, my experience, I don't need to do this, but I think if we open the throat is better, but the vein no need to open because the material is not much in this stent. And next, we do angio later. We put the pigtail in the innominate vein. You see, almost no obstruction of the innominate. Yeah, and the pressure we measure. You can show the pressure now. The pressure of the innominate artery vein. Sorry, innominate vein is about 12, similar to the HVC and the RA. I don't think any obstruction now. What do you think?
Oh, it's very good. I'm glad that we noticed that point so that you could go across, dilate the cell, and restore continuity of the innominate.
Yeah.
I think the final result is very good. And Dr. Srinivas,
Yeah.
you should see this. It's your point which led to the discussion, the demonstration, and the restoration of continuity of innominate. Thank you.
Okay.
Yes, even
Any
innominate is
question or
looking small,
comment?
I don't know why.
Sorry, Srinivas?
Innominate is looking smaller than normal.
Yeah, but at least it is there.
It's there now. Yeah.
Of course, it's a little bit smaller than before.
Yes.
After we delete the stenosis, it becomes a little bit
Yes.
smaller.
Yeah, I think in our final result is quite fine. The SVC gradient is abolished. You have a decent SVC, restored continuity of the innominate. So, can we conclude the day's program? Thank you very much.
Okay,
Thank you, sir. Thank you.
Manish.
Thanks a lot.
Thank you.